بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما يا كريم. بنكمل الموضوع اللي احنا ابتديناه على الفاكوماتوسيس، وابتدينا نتكلم على النيورو فايبروماتوزس تايب 1 على أساس هو ده يمكن أشهر واحد فيهم على الإطلاق، ومشينا فيه شوية لحد لما وصلنا عند النيوبلاستيك ليجنز، وكلمنا في النيوبلاستيك ليجنز على الأوبتيك نيرف جلايوما والجلايوما of the visual pathways، وانتقلنا دلوقتي إلى الهايبوثالاميك جليوما اللي هي بتعتبر جزء من الامتداد بتاع الأوبتيك نيرف جلايوما through the optic nerve canal to affect the chiasm and also to appear in the suprasellar area. And this is a good example of a big hypothalamic glioma with almost homogeneous post-contrast enhancement. This lesion was pathologically proved to be a juvenile pilocytic astrocytoma and treated by chemotherapy. This is the follow-up after 3 months showing relative development of necrotic tissue within the tumor, but there is appreciable increase in the extent of the hydrocephalus, and this may be related to let us say perilesional edema, for example, or some kind of increase in the size of the tumor due to the development of central necrosis. The second most common brain tumor in patients with neurofibromatosis is the brainstem glioma. And the brainstem glioma is one of the tumors that affect predominantly the region of the bones, and it is usually of the pilocytic type or pilocytic astrocytoma. You remember that the age incidence of an optic nerve glioma is about 6 years old, and incidence of brainstem glioma is a little bit 8 years older than the age incidence of optic nerve glioma. Because of the strategic location of the tumor in relation to the fourth ventricle as well as the aqueduct of Sylvius, there is a possibility of development of obstructive hydrocephalus, which may need a shunt tube to relieve this hydrocephalus. Other symptoms will include cranial nerve pulses, ataxia, and hypotonia. The brainstem gliomas in adults with neurofibromatosis type 1 are relatively less common compared to those in children, and the malignancy in brainstem glioma is usually seen in young adults, and this is the incidence, which is less than 1% of cases. The majority of these gliomas occur in the bones, and these types of gliomas may progress to a high grade, as I have mentioned before, and the tumor progression may result in evident decrease in the survival rate. Brainstem gliomas are expansile. They enlarge the affected part of the brainstem. They are infiltrative, can extend into the middle cerebellar peduncle and affect the cerebellar hemisphere. They have exophytic extensions into the prepontine cistern, and they go anterior to the basilar artery, which may be engulfed within the tumor tissue. About 50% or maybe 40% of these lesions will show contrast enhancement. And you remember that contrast enhancement means that the tumor is progressed to an advanced a malignant stage or a more malignant stage. We have taught previously that brainstem glioma, which is not enhancing, belongs to the pilocytic type of astrocytomas, and that which enhances belongs to the glioblastoma multiforme. Sometimes if the brainstem glioma is not enhancing, it may be mistaken for other non-neoplastic pathologies occurring in the brainstem, and at that time you may have the help of MR spectroscopy to discriminate between both. The literature says also that we may detect some calcium or cystic changes in the tumor, and PET-CT is not recommended to evaluate brainstem gliomas, and according to the literature, they may be used to differentiate between aggressive and non-aggressive lesions. زي ما قلت قبل كده the hydrocephalus في neurofibromatosis is known, and there are many possibilities like the aqueductal stenosis or aqueductal webs. Also the tumors like chiasmatic and hypothalamic tumors, which are intimately related to the region of the foramina of Neuro and the anterior part of the third ventricle. Also, pilocytic astrocytoma is one of the manifestations or the neoplastic lesions occurring in patients with neurofibromatosis type 1. And this pilocytic astrocytoma, كلنا عارفين the diagnostic criteria, the cyst with an enhancing neuron nodule, and it occurs predominantly in the posterior fossa, and so the nodule may have variable appearances. ممكن تبقى صغيرة، ممكن تبقى كبيرة، ممكن تحصل على السبتم، ممكن يحصل intracystic hemorrhage. معظم الحاجات قلناها قبل كده في الكلام على البرين tumors. And this is an example pilocytic astrocytoma occurring supratentorially. In the T2 weighted image, the tumor is cystic with a solid component, and in the T1 post contrast, you got enhancement of the solid component. Many times you got multiple lesions distributed in the brain and in the spine, like in this patient with astrocytoma in the thalamus on the right side, with compression of the third ventricle and the hydrocephalus. Another astrocytoma which is located in the brainstem, and the big astrocytoma in the spinal cord involving the medulla and the craniocervical junction, as well as a good part of the cervical spinal cord. Another example of pilocytic astrocytoma, you see here, this is a lesion which is of low signal in the T1, high signal in the flare, marginal post-contrast enhancement, and some diffusion restriction of the enhancing margin. Ganglioglioma is also one of the tumors encountered in patients with neurofibromatosis type 1. And actually, we do not have enough criteria to discriminate this tumor histopathologically from imaging. But all what you can say that there is a space-occupying lesion with a cystic and solid component, and the solid component is enhancing heterogeneously with evident surrounding perifocal brain edema and significant mass effect exerted on the ventricular system with contralateral shift of the midline. Then you may suggest the possibility of glioma, or you may say because of the enhancement that this may represent a glioblastoma multiforme. Actually, the diagnosis of ganglioglioma is only reached after surgical biopsy or resection of the tumor. Then one of the pathognomonic features of neurofibromatosis type 1 is the plexiform neurofibroma, which is a big neurofibroma. It is a benign lesion arising from the peripheral nerves and diagnosed in early childhood, and is considered, as I have mentioned, a pathognomonic feature of neurofibromatosis type 1. There is a significant risk of malignant transformation of this plexiform neurofibroma, and the incidence is about 8% in larger tumors. This is an example of a facial plexiform neurofibroma affecting the periorbital soft tissues as well as the facial structures, and you got significant post-contrast enhancement of the lesion. Malignant peripheral nerve sheath tumor is the malignant part of neurofibroma and schwannomas. Previously, it was known as neurofibrosarcoma, but in the recent literature, it is known as malignant peripheral nerve sheath tumor. And it represents about 8% of the soft tissue sarcomas, and 50% of these lesions seen in patients with neurofibromatosis type 1, usually in the young or middle-aged adults. The literature indicated the relation between irradiation and the development of this tumor, but some of the malignant peripheral nerve sheath tumors can arise de novo or on top of an existing neurofibroma or plexiform neurofibroma. The tumors are usually large and they usually invade the surrounding structures. These tumors carries a poor prognosis, and these are the poor prognostic factors: the presence of neurofibromatosis type 1, the large size of the tumor, the location in the trunk, and the high grade of histologic features. Malignant peripheral nerve sheath tumors are rare in the brain, and about 55% of these lesions occur in the eighth cranial nerve, and about 25% of the patient develop metastatic deposits. The literature says that you need 2 or more criteria in this, let us say, plexiform neurofibroma to suggest the possibility that this tumor has developed a malignant potential. If the tumor mass is more than 5 centimeters, if there is peripheral contrast enhancement, the presence of edema around the lesion, the presence of cystic areas within the tumor, and the heterogeneity on T1 weighted images. Then these are the MR diagnostic criteria of malignant peripheral nerve sheath tumor. Number one, mixed signal intensities, irregular contour with central areas of breakdown and necrosis, compression of the adjacent brain tissue, invasion of the surrounding, heterogeneous post-contrast enhancement, and also invasion of the adjacent bones. Metastasis from this malignant tumor go to the lung, but metastasis to the brain is extremely rare. This is a female child with lumbosacral pain and weakness, and the CT scan of the abdomen showed the big tumor tissue with foraminal extension, suggesting its neuronal origin. Actually, whenever we see a lesion that has an intraforaminal component and extraforaminal component, you think of a nerve sheath tumor. And this tumor is big with central areas of breakdown, invasion of the adjacent structures, and it happened to be a malignant peripheral nerve sheath tumor. As I have mentioned, that metastases of malignant peripheral nerve sheath tumor to the brain are extremely rare. And this is an example of a patient with peripheral nerve sheath tumor in the lower limb. He had a below knee amputation, and the pathology showed malignant peripheral nerve sheath tumor. The MRI of the brain post-contrast showed a big heterogeneously enhanced lesion that is representing a metastatic deposit from the malignant peripheral nerve sheath tumor. Then we have finished most of these items, and we are left by the remaining items, including the dural ectasia, the moya-moya phenomena, the craniofacial abnormalities, the spinal lesions, and musculoskeletal manifestations. Of course, one of the well-known criteria of neurofibromatosis type 1 is the dural ectasia. And the dural ectasia, meaning that the cecal sac is ectatic, and you got, due to CSF pulsations, impressions on the neural elements and the back of the vertebral bodies, resulting in this pathognomonic appearance. And the dural ectasia can occur at any point of the dura, starting from the skull base down to the sacrum, and they are outpouching through the enlarged neural foramina. In advanced conditions, these dural filled CSF spaces can protrude through the neural foramina, and they erode the adjacent bones and displace the adjacent organs. 80% of dural ectasia are found in patients with neurofibromatosis type 1. But dural ectasia is seen in about 90% of cases of Marfan syndrome. It is also seen in Ehlers-Danlos syndrome, ankylosing spondylitis, and chondroplasia. This is an impressive example of dural ectasia, where you got marked scalloping of the posterior border of the vertebrae, as well as you can see here in the axial image. So these are the radiologic findings: erosion of the posterior part of the vertebral body, wedging and scalloping of the vertebral body, pedicle erosion, foraminal enlargement and kyphosis, spinal deformities, vertebral fractures and dislocations. The literature says that neurologic deficit is rare because the spinal canal is wide. And this is another example of dural ectasia in the cervical spine, with the classic scalloping of the posterior aspect of the vertebral bodies and marked widening of the spinal canal. One of the dural lesions also found in neurofibromatosis type 1 is the meningocele. And these meningoceles and dural ectasia are two of the manifestations seen in neurofibromatosis type 1, where dural ectasia means the circumferential expansion of the dura, while the meningocele means localized dilatation of the dural sac, which may occur on the lateral aspect, which is common in neurofibromatosis type 1, and this is known as lateral thoracic meningocele. Um, and another manifestation is the vascular manifestations, and the vascular manifestations may include what's known as moya-moya like syndrome, and also it may include cerebral arteriovenous malformation and aneurysms. The vascular malformations, as according to the literature, are not strictly associated with other features of neurofibromatosis. And you know that moya-moya disease may be primary or secondary, and the secondary types are usually seen in patients with neurofibromatosis type 1 or those who has been exposed to radiation, which will result in vasculopathy and narrowing of the vessels. And this is an example. If you can appreciate that the internal carotid artery on the right side is reduced in caliber, and also the A1 segment of the anterior cerebral artery and the most of the middle cerebral artery are markedly attenuated. And as I have mentioned, that moya-moya can be secondary to radiation or neurofibromatosis related lesion. Most of the cases are primary manifestations of neurofibromatosis type 1, and some of the literature indicate that MRA should be included in the routine evaluation of patients with neurofibromatosis type 1 in order to detect the vascular abnormalities. This early detection will prevent cerebrovascular complications and also will help to select patients for more interventional management. This is a female child, 7 years old, with multiple cafe au lait patches, axillary freckling, and leash nodules in the eye. You can easily appreciate the presence of high signal intensity lesions in the white matter, and also you may see in the MRI and MRA that there is marked attenuation of the proximal part of the middle cerebral and most of the anterior cerebral arteries. Then some words about the craniofacial abnormalities, which are a lot, including, as I have mentioned before, the sphenoid wing dysplasia. We have discussed this in the previous lecture. Also, orbital manifestations. Then we will say something about temporomandibular joint and dental abnormalities. We have mentioned something about meningoceles and meningoencephalocele, and also we mentioned something about the dural ectasia. One more thing to be added is the presence of macrocephaly, and this is a common finding in neurofibromatosis type 1, and it may be regarded as an indication for the presence of an underlying increase in the intracranial pressure. The changes in the mandible include, number one, hypoplastic maxilla and mandible, affection of the temporomandibular joint. You see that the mandibular ramus and the condyle are somewhat normal on this right side, and they are markedly attenuated on the left side, which may result in temporomandibular dysfunction, malocclusion, and masticatory or mastication problems. Then another manifestation in the mandible is the periapical segmental dysplasia, as you can see in this example. But the dental age is usually similar to general population. Dental caries is not a feature of neurofibromatosis type 1. One of the manifestations is enlargement of the mandibular canal and retroganthic mandible and maxilla, as you can see in this photograph. Then some of the oral manifestations include overgrowth of the gingiva, as you can see here, and prominent lingual papillae. Some of the mucosal tumors like neurofibromas, as you can see here, and also neurofibroma of the lip with a change of the voice quality. In the spine, the most prominent manifestation is scoliosis, but you may got vertebral hypoplasia, spondylolisthesis, spinal canal stenosis, and Chiari-1 malformation is seen in patients with neurofibromatosis type 1 in about 10% of the cases, and syringomyelia can be associated with Chiari type 1 or may not. These are some of the findings in neurofibromatosis type 1, like cervical kyphosis and spondylolisthesis, as you see here, lytic spondylolisthesis of L5 over S1. And you remember that the unidentified bright objects, which are seen commonly in the brain, they may be identified also in the spinal cord, and they show the similar criteria. They appear of low signal in the T1, high signal in the T2. They do not exert any mass effect, and they do not show any post-contrast enhancement. Spinal tumors are also well known in patients with neurofibromatosis type 1, and they are seen in about 40% of the cases. They include a big number of tumors like the neurofibromas, which can occur inside the spinal canal and along the nerve roots, extending in the pre and the paravertebral areas. Finally, the skeletal manifestations in neurofibromatosis type 1, according to the literature, about 50% of these patients will experience some severe orthopedic manifestations. In the spine, as I have mentioned, you got scoliosis and spinal deformities, and also you may got neurofibromas everywhere in the body, bone dysplasias, and endocrine disturbances. And spine, we have mentioned the manifestations like the kyphoscoliosis, vertebral scalloping from dural ectasia, intrathoracic meningocele, hypoplastic posterior elements, enlargement of the neural foramen. And the rest of the skeleton, you may got ribbon-shaped or penciling of the ribs. The tibial pseudoarthrosis is one of the well-known stigmata of neurofibromatosis type 1. Bone dysplasia of the tibia, multiple non-ossifying fibromas, limb hypertrophy, absent or hypoplastic fibula, lambdoid sutural defects we have mentioned before, and localized gigantism. And this is an example of what do we mean by gigantism, and is known as elephantiasis neuromatosa. You got enlargement of the soft tissues of the hand, and these soft tissues may also be also associated with bony changes. And this is an example of penciling or ribbon shaped ribs on the left side. And here is an example of bone dysplasia of the tibia and also the fibula. You got this bowing deformity, which is one of the criteria of neurofibromatosis type 1. Congenital pseudoarthrosis may be an advanced stage of tibial dysplasia where you got a defect in the tibia, and this defect will form a false joint between the edges of the fibula, and this is not a fracture, and it will not heal by the ordinary fixation methods. The changes in the fibula may include atrophy, absence, or thinned out fibula. This is an example of tibial dysplasia and hypoplasia of the fibula. Non-ossifying fibromas are multiple in patients with neurofibromatosis type 1. You remember the fibrous cortical bone defect can be multiple without association with neurofibromatosis type 1, but non-ossifying fibromas, as you can see in this example, they are multiple, and one of them has developed the pathological fracture. Thank you very much.